Welcome to The Explainer. I'm so glad you're here today because we're tackling something that is, quite literally, a race against the clock. We're looking at the cascade of shock. Once this dynamic, rapid cascade of systemic failure starts, the body's normal, perfectly balanced systems just start spiraling downward. Time is absolutely everything here. So let's jump right in and see exactly what happens when that countdown begins. So here's a question for you. Could a slightly elevated pulse really be the first warning sign of multi-organ failure? I know, it sounds a bit extreme, right? I mean, our heart rate jumps when we're stressed out or just running to catch a bus. But in a clinical setting, that subtle, almost invisible shift, that's the ticking clock. It might be the very first whisper that the body is about to step off a cliff. Miss it, and that window to turn things around starts slamming shut. Okay, so what exactly is shock at its core? Basically, it's a critical decrease in blood flow that results in inadequate oxygenation to your tissues. Now, in a healthy person, the body just hums along in perfect homeostasis, and that balance relies on three totally non-negotiable pillars. You need sufficient cardiac output, an uncompromised vascular system, and enough blood volume. If your tissues can extract and use the oxygen delivered to them, great, all is well. But what happens when that engine starts to sputter? To understand the breakdown, we really have to look at the hemodynamics of the engine. Cardiac output is just the amount of blood pumped per minute into the aorta. But the real tripwire for shock is a sustained drop in mean arterial pressure, or MAP. MAP is your cardiac output multiplied by your systemic vascular resistance. So if cardiac output drops, or circulating blood volume tanks, or those blood vessels suddenly dilate and get way too wide, MAP plummets. And a sustained drop in MAP, well, that's the starting gun for the cascade of shock. Let's put a number on our first type, hypovolemic shock. This one is triggered by a decrease in intravascular volume of 15% or more. We're talking about a literal physical loss of blood volume or a major drop in blood returning to the heart. Simply put, the tank is either leaking or it's just emptying out way too fast. But hey, what if the issue isn't the fluid volume, but the actual pump itself? That brings us to cardiogenic shock. This is when the heart's pumping ability is compromised, usually by something severe like a massive heart attack. Cardiac output is reduced, so blood pressure falls. But notice what goes up. Pulmonary capillary wedge pressure spikes because blood is backing up into the lungs, and systemic vascular resistance shoots up too, as the body desperately squeezes those blood vessels tight to keep the pressure up. The pump is failing, and the whole system is backing up. Now, beyond blood loss and failing hearts, the triggers for shock are honestly staggering. You've got neurogenic shock from spinal cord injuries, anaphylactic shock from severe allergies, and septic shock stemming from severe infections in chronically ill or debilitated patients. These triggers are wildly different, right? I mean, spanning from a simple bee sting to a catastrophic car crash. But make no mistake, no matter the trigger, they all start the exact same dangerous physiological clock. So what does this ticking clock actually look like? It happens in three distinct stages. Stage 1 is pre-shock, Stage 2 is shock, and Stage 3 is multi-organ failure. The absolute most crucial thing to remember here is that time is tissue. As this timeline progresses, that window for us to medically reverse the damage closes incredibly fast. All right, let's look at Stage 1, pre-shock. This is early, it's reversible, and the body is heavily compensating. When that MAP falls, baroreceptors instantly detect the drop. They sound the alarm, and the sympathetic nervous system kicks in, increasing the heart rate to compensate. But here's the genuinely terrifying part. The symptoms right now are almost completely imperceptible. The only real clue? A slightly elevated pulse. The body is hiding the crisis from you, and those compensatory mechanisms, they are strictly short-acting. If we don't fix the underlying cause, we hit a critical number, 20. Stage 2, which is progressive or immediate shock, officially begins after a sustained decrease in mean arterial pressure of 20 millimeters of mercury. Those short-term fixes from Stage 1, they're totally exhausted. The body literally can't fake it anymore. The tension escalates, and down on a microscopic level, total panic sets in. So what does cellular panic actually look like? Well, it looks like a massive metabolic shift. Because oxygen is scarce, cells are forced to switch from highly efficient aerobic metabolism over to anaerobic metabolism. And the cost of this survival tactic is incredibly steep. Anaerobic metabolism churns out lactic acid. As that lactic acid builds up, generalized acidosis occurs. The cellular sodium-potassium pumps fail, the cells start to swell. Basically, the very building blocks of the body are drowning in their own acidic waste. As the cells panic, organ perfusion just plummets, and we start seeing very predictable domino-like effects across all the body systems. The cardiovascular system ramps up the heart rate and triggers severe vasoconstriction to force blood to vital areas. The lungs speed up their rate trying to blow off that acid, leading to respiratory acidosis. The GI tract basically just shuts down. Neurologically, you see a decreased level of consciousness because, well, the brain is hypoxic. And the kidneys? They stop making urine completely to conserve every single drop of fluid. The body is actively sacrificing its limbs and organs just to save the heart and the brain.
Clinically, this unfolds like a rapid-fire sequence of alarms. Tachycardia, tachypnea, diaphoresis, sweating as the sympathetic nervous system just redlines. The systolic blood pressure finally drops, but you have to pay really close attention to the narrowing pulse pressure. That's when the difference between the systolic and diastolic numbers shrinks. It is a wildly critical early indicator of shock. You've got to spot these subtle signs while the body is desperately compensating, because if you don't, cardiopulmonary failure is next.
And if cardiopulmonary failure does hit, we are in stage 3. Multi-organ failure. This is refractory irreversible shock. Honestly, the gravity of this stage just cannot be overstated. Generalized tissue anoxia has led to widespread cellular death. The death of cells leads directly to the death of tissues, which inevitably causes the death of the organs. Once the cascade reaches this point, the damage is completely done. Absolutely no treatment is going to reverse it.
This is exactly why anticipating shock is everything. To stop this downward spiral before stage 3, healthcare teams have to deploy a massive diagnostic toolkit. We check hemoglobin and hematocrit for blood loss, arterial blood gases to check oxygen and acid levels, BUN, electrolytes, creatinine, and lactate to see if the kidneys are failing or if cells are stuck in anaerobic mode. We pull blood cultures for sepsis, cardiac enzymes for cardiogenic shock, and do imaging like echocardiograms. It's literally a full system audit, and it has to be done in minutes.
Once that rapid-fire detective work pinpoints the cause, emergency collaborative care kicks in. The goals here are straightforward but incredibly difficult. Treat the underlying cause, increase arterial oxygenation, and improve tissue perfusion. The immediate steps: first, oxygen therapy. Pretty much all clients with shock need this, often requiring a ventilator. Second, fluid replacement. And third, targeted medications. Let's look a bit closer at those last two. Fluid replacement therapy is heavily relied upon. It's the absolute most effective treatment for hypovolemic shock, but it's also a major staple for neurogenic and septic shock too. We use crystalloid solutions like normal saline and lactated ringers to just fill the tank back up. Then we use colloid solutions like albumin or dextrin to pull fluid into the vessels, and naturally, actual blood products if the patient is bleeding out. Bottom line, you have to give the pump something to pump. Then comes the pharmacologic therapy. This is a powerful arsenal used to directly manipulate the cardiovascular system. We use vasoconstrictors like norepinephrine to clamp down those vessels and force the pressure up. We bring in inotropes like dopamine and dobutamine to make the heart muscle squeeze significantly harder. Or, on the flip side, we might use vasodilators like nitroglycerin to reduce the workload on a failing heart. And depending on the exact cause, the team might also be pushing antibiotics, sodium bicarbonate, or epinephrine. But listen, all the medicine in the world relies on absolutely exceptional implementation at the bedside. The nursing process here is intense. Preserving cardiac output means continuously monitoring blood pressure, heart rhythm, and peripheral pulses. We're measuring every single drop of intake and output to ensure those kidneys are still working. We monitor skin color, turgor, and temperature to gauge tissue perfusion. We're constantly assessing mental status, and crucially, we're trying to relieve the intense anxiety for both the client and their family. The ultimate goal? Making sure the client does not progress to uncompensated shock. We've looked at the mechanics of the engine, the triggers of failure, and the absolute cellular panic of a body desperately trying to save itself. We know that the window for reversal closes incredibly fast, so I'll leave you with this final, critical thought. When you're standing right there at the bedside and the monitors are beeping, will you catch that subtle narrowing of a pulse pressure before the clock runs out? Thanks so much for joining me on this deep dive into the cascade of shock. Stay focused, keep learning, and I'll catch you in the next explainer.